Your presence truly adds value to this scientific platform, and we are grateful to have you here. Today's session is designed to encourage meaningful academic exchange and practical clinical insights, and I am confident it will be highly enriching for everyone present out here. It is now my privilege to introduce our business head of Team Maxlock, Mr. Upendra Tanwar sir, whose vision and leadership continues to inspire us in our commitment towards advancing medical education and strengthening partnerships with medical fraternity. I request Upendra sir to kindly address the gathering and take the program forward.
Yes, dear colleagues, friends, ladies and gentlemen, I warmly welcome you all to this academic evening, focusing on practical challenges which we face in our day-to-day life. Today's meeting has been thoughtfully crafted and curated around three highly relevant and commonly encountered clinical conditions: GERD, which is beyond acid control; hyperuricemia, when and what to treat; and neuropathic pain in diabetics. Before we begin, I would like to acknowledge and welcome our program director for today's CME, respected Dr. C.G. Agarwal sir, who is your teacher in the college days and has been continuously teaching and guiding us till date. He is senior physician and diabetologist based in Lucknow, over 55 years of extensive clinical experience, expertise in diabetes management, infectious diseases and internal medicine, trained in internal medicine with advanced exposure through Harvard Medical School and American board programs, and lot many more things. I don't think he needs any further introduction, as he is known to all of us and liked by all of us. So to start with the ceremony, I would request Dr. Agarwal sir for the lamp lighting ceremony, and all the three speakers, Dr. Puneet Mehrotra, Dr. Sant Pandey and Dr. Vaibhav Shukla. So please come on the dais for lamp lighting ceremony. Proportion of patients in our day-to-day practice, yet it often remains inadequately addressed beyond symptomatic acid suppression. For this, I invite Dr. Puneet Mehrotra sir to talk on this important topic and come on the dais, please. I also invite Dr. Sandeep Chaudhary, Dr.
More than 30 years of experience, President UP Chapter, Indian Association of Gastroenterology and American College of Gastroenterology. He is expert in advanced GI endoscopy and nephrology. I welcome Dr. Puneet to start his talk. Thank you.
I can talk about GERD. Most of us know a lot about GERD as such. So it was modified to beyond acid control. Most of us treat GERD with PPIs, which are basically acid controlling drugs. So what I will do in next 20 odd minutes is what is beyond acid control. Let's understand why this topic is important. Most of, as in our day-to-day practice, we find that many patients remain symptomatic despite PPI. You have patients in your clinic, you are giving PPI regularly, they come back to you and say that symptoms are still persisting. At times you find that PPI is not working. You keep on switching PPI from one brand to the other, but they're still not enough. And all of us are concerned about the long-term side effect of the drug. Plus, GERD is a multifactorial disease. We will understand this in the next few slides. Then there is a role of motility. I think all of us sitting here in the audience often write combination of PPI with prokinetics. Is there a role? Basically affecting the esophageal motility, gastric emptying. Again, there is another entity called hypersensitivity. बहुत से लोग आपने देखे होंगे कि देखते हैं कि पेशेंट के अंदर मिर्चा खाते हैं सारा प्रॉब्लम हो जाता है, अदरवाइज कोई दिक्कत नहीं. Small amount of spice causes lot of symptoms of GERD, hypersensitivity. There could be barrier dysfunctions. It could be a clearance dysfunction. Clearance means acid is not being cleared properly by the esophageal muscle. We need a phenotype-based management of GERD, not run-of-the-mill GERD. So these are my pointers that why understanding GERD beyond acid control is important. Let's go one by one. Clinical definition. This is run-of-the-mill definition. GERD could be of two types. A standard GERD where endoscopic findings suggest reflux-related changes. Other would be a patient who had undergone an endoscopy referred by CG sir that do an endoscopy for this patient. Endoscopy is normal. So these are non-endoscopic GERD. We have barrier dysfunctions. There are patients who do not respond to standard PPI. Why they do not respond? Because the reflux which is getting is weakly acidic. It's a non-acidic reflux. A non-acidic reflux is not likely to respond to standard PPI. That's why I think of beyond acid control. What do? You do an endoscopy, it's negative. You do a pH test for GERD, it's negative. If your symptoms are still suggestive of GERD, what do you think of? Reflux hypersensitivity. This will be one more entity. Functional heartburn. You do everything, you land up giving a neuromodulator at the end of the day and the patient's symptoms get better. That's how these patients keep on moving from one doctor to the other. पहले वाला ने PPI लिखा, दूसरे ने PPI चेंज किया, तीसरे ने प्रोग्राम के ऐड करता है, चौथा वाला सब बन गया, नटोजलाम दे दिया, पेशेंट ठीक हो गया. So these are neuromodulators. So it really matters in clinical practice. So thinking about GERD beyond acid control is important in clinical day-to-day practice. With a small amount of data, you can understand why beyond acid control is important. 40% patients still have symptoms on BD dose of PPI. PPI hearing rate for esophagitis is 85 to 90%. These are classical GERD patients. But symptom control is 50 to 60%. There's a good 50% patients still remain symptomatic despite PPI. So before blindly increasing a dose of PPI, do check for compliance, timing of the blood taken, rule out eosinophilic esophagitis, plan an impedance pH-metry before you switch to another PPI or increase the dose of PPI. One should also rule out hypokinesis over esophageal sphincter, ineffective or absent esophageal motility. So these are the points which you should look for in your patients of GERD on PPI not responding to it. So it is beyond acid control. Epidemiology, what Satish said, is a very common prevalent condition. I am not going to the details of that. Pathophysiology, what sir has taught us in our medicine days, कोई बीमारी अगर हो रही है, कुछ imbalance है between injurious and defensive factors. यही GERD में होता है. Risk factors. Satish would be interested in it. Alcohol. Does it precipitate GERD? Does it affect GERD? No. The data is not very clear. That does not mean I should consume a lot of alcohol, but the data is not very clear about it. Waist circumference. And यहाँ जितने physicians बैठे हैं, सब आजकल मैसेट की बात करते हैं और waist circumference की बात करते हैं. वो शायद मैसेट में तो लागू हो ही रहा है, but in GERD is equally relevant. अगर आपने बेल्ट टाइप करनी हुई है, obesity है, GERD produces precipitation. So waist circumference has an important role in pathophysiology precipitating GERD. Dietary factors. ये एक बहुत कॉमन प्रॉब्लम है कि डाइटरी फैक्टर्स का क्या रोल है GERD. हम लोग सब एज ए फिजिशियन प्रिस्क्राइब नॉर्मल डाइट, स्मॉल मील्स, फ्रीक्वेंट मील्स, ब्लैंड डाइट्स. इज देयर अ डेफिनेट एविडेंस फॉर इट? देयर इज नो साइंटिफिक डेफिनेट एविडेंस बेस्ड ऑन डेटा अवेलेबल whether dietary factors are important in GERD precipitating or not. But yes, there could be individual variation. A particular patient might find that this particular diet item causes GERD, this one doesn't cause to me. But a word about coffee is important. आजकल coffee बड़ा fad है. Black coffee, white coffee, grey coffee, lot of coffees are there. Green coffee. So coffee again, the data is not very clear. So you can allow your patient a cup of coffee. The data is not very clear. You might find a particular individual who is not happy with having a cup of coffee, precipitates GERD, but that's an individual variation. Medical data is not available on role of coffee in precipitating GERD. symptoms, we all know about it. Atypical, I just discussed it. Alarm symptoms, we are able to discuss it. But sir, मैंने इसको लास्ट में लाइन इसलिए लिखा कि हमारे पास जितने हम यहाँ बैठे हैं, all of us have patients coming to us, सब बहुत acidity होता है. When you go back and ask them, what do you mean by acidity? They would say, acidity होती है सर, कुछ गैस का बनता है, पेट थोड़ा भारी होता है, फूलता है. But they would continue to say acidity होती है. So if you clearly go and poke them, then what do you mean by acidity? Most of them would say, कोई सीने में जलन नहीं है, कोई खट्टी डकार नहीं है, but symptoms are acidity. So that is a vague functional dyspepsia which is often branded as acidity by the patient. And these patients in a busy OPD are often prescribed PPI with no response. Let's talk of atypical symptoms. These are very common. Chronic cough, asthma-like symptoms, laryngitis, hoarseness, recurrent sore throat, dental enamel erosions. Here, what is most important to understand in this slide is that before you label these atypical symptoms as GERD conspirating them, make sure that they have symptomatic GERD. Because all these atypical symptoms are often associated with symptomatic GERD. GERD is to be symptomatic before you say that these features are part of atypical symptoms. Again, science keeps on throwing you challenges. Association versus causality. Association of these atypical symptoms with GERD is well known. But causality, the data is not very clear. To say that it completely follows all these symptoms is difficult. Need a lot of PH studies to confirm whether particular patient's symptoms are related to classical GERD or not. But association is definitely there. Alarm symptoms, हम सबको पता है alarm symptoms. Dysphagia, painful swallowing, upper GI bleeding, unexplained weight loss. But जो मैं यहाँ important बात mention करना चाहता हूँ slide में, chest pain. I think Dinesh is there, Sir is there, and a cardiologist and physicians are there. These patients often shuttle between a gastroenterologist and a cardiologist. GI OPD, a very busy clinician, is well bound to miss this GI patient. Because ये patient typically कह के आते हैं, acidity हो रही है, जलन हो रही है, खाना खाते हैं पेट भारी हो रहा है. But in the same breath, they would say, सीढ़ी चढ़ते हैं तो भी जलन होती है, या भारी हो जाता है. They would say burning sensation in the chest while climbing stairs. So that is what should be an alarm symptom for a gastroenterologist and a physician looking for GERD. These patients are often missed and treated as GERD and end up in a cardiac ICU at some point of time. I have seen lots of such patients in 30-35 years who are TMT tests and they are positive for TMT. I think Dinesh would agree with that. एक पेशेंट और है, ये बहुत important finding. I think this message should go to the residents in case they are there. That if you have a patient who has classical symptoms of GERD and he says there is nasal regurgitation, रात में सोते हैं तो खाना नाक से आ जाता है. ये वाले पेशेंट्स लंबे समय तक GERD की दवा खाते हैं without much of response. They ultimately land to the GI physician and they are often diagnosed as echinacea cardia. This is basically esophageal motility disorder or LES tightness of it. So these echinacea cardia patients often initially present with reflux, but if you have a patient in your clinic, sale of nasal regurgitation is not classical GERD. GERD nasal में नहीं होता है. In case it is happening, think of echinacea as a possibility. Because these patients reach us very late, esophagus gets dilated, even treating LES tightness also doesn't help them. So this was the message in this particular slide. I think जो लोग endoscopy नहीं करते हैं to diagnose GERD, empiric PPI therapy, 8-week trial, symptoms disappear, it's classical GERD. Esophageal manometry, not all of us do it, but this is what you can do with it. Peristalsis देख सकते हैं, LES assessment देख सकते हैं. When you need these esophageal manometry or page studies, that's the message in the slide. Persistent symptoms despite PPI therapy. What to do next? Look for esophageal dysmotility. Look for a pH study. You might be dealing with hypersensitivity, functional heartburn, or esophageal motility disorder. This is not classical GERD. So that's what GERD beyond acid control. Alarm symptoms, all of us know that. Is there a role of endoscopy in GERD? To diagnose GERD, there is no role of endoscopy. To treat GERD, there might be some role of endoscopy. If there are alarm symptoms, definitely do an endoscopy. If there is failure of empiric therapy, do an endoscopy. If there are long duration of symptoms, look for an endoscopy at least. If you are planning a surgery in that patient, preoperative evaluation is important. Barracks is something which needs to be evaluated in long-standing GERD. So let's move on to the treatment. GERD beyond asset control. Therapeutic principles would be determinants are clinical and endoscopic. That means आप clinical और endoscopic basis कोई decide करेंगे GERD था या नहीं. किसी भी treatment का goal है treat that particular patient, get him relief from the symptoms. That is the goal of the treatment. And what are the options available? I think I will not stress the lifestyle modification. यहाँ सबको पता है lifestyle modifications क्या होते हैं. TPI के बारे में all of us know it. The only message which I want to give to the audience is all PPIs are same. There is no difference in either of them. You can use any of them. All prazols are same. Anesthetic antacids, some of them use करना सिखाया भी था. It's still a good drug to use, especially if you have rhinophagia, if you have hypersensitivity, functional heart burns. Anesthetic antacids work well. H2RA, you still use it but sparingly now. I'll touch on propanol a little later. जो दो नई दवाइयाँ हैं जिनका आजकल भरमार हो गया है लोग ओपीडी में डेली के नया रहता है that is PCAS, यानी monoclonal. I have only 3 points to give to the audiences. It's a good drug, that is one. Why it is good? There are 3 points here. I think all the panelists will agree with that. One, it can be taken any point of time. Means से कोई relationship नहीं. It's a big plus for patients of GERD, dyspepsia, acidity. आप कभी भी खा सकते हैं. रात में आपने एक अच्छा चिकन खाया, साथ में एक थोड़ा वाइन भी लिया और जलन हो रहा है तो जाकर वाइन के साथ खा सकते हैं. It works faster. 1, 2, rapid action. Works rapid. 3, non-standard effect. 4, nocturnal acid breakthrough में monoclonal works well. तो उनके हम पूछा है. हम लोग जो एंडोस्कोपिक प्रोसीजर्स करते हैं जिसमें अल्सर अल्सर बनते हैं, OM कर रहे हैं, EVM कर रहे हैं, EMR, ESDs कर रहे हैं. Healing rate of ulcers is faster in monoclonal as compared to proton which are available. So ये major advantages हैं which are give an edge of monoclonal over many other molecules which are available. I'm not saying other than that. आजकल रैप patient बहुत आ गया market में. I think last 5 years में I have seen lot of companies. I think all of us would agree with that. Last 5 years suddenly rap patient बढ़ गया market. I don't know why, but everybody is coming with a rap patient. रैप patient का advantage for nocturnal acid breakthrough ही है. Otherwise कोई normal antacid की तरह use नहीं कर सकते. It is not an anesthetic antacid. It has to be given to those patients who have nocturnal acid symptoms, especially those who have atypical symptoms. That means laryngitis, sore throat, cough, का sensation करते रहते हैं सारी रात, उनके लिए important है. Because this prevents the nocturnal acid breakthrough by forming a layer over the stomach, and thus the acid is prevented to get entry into the esophagus. So rap patient have a definite role. एक एक्स्ट्रा दवाई चला हुआ था, अभी भी चल रहा है. Is there a role of extra दवाई in GERD? There is an inverse association with it, but routine testing is not recommended. So routinely giving an anti-extra treatment in GERD is not recommended. Prokinetics, I think इस पे एक मिनट बात करेंगे. Because prokinetics are combination which is used by all of us, or includes me also. So all of us use combination instead of single drug. For whatever reason we don't understand that. But prokinetics combination for treating GERD is not indicated. It's only indicated in situations where the consultant you feel there is poor esophageal emptying or the gastric emptying is slow, especially diabetics. उनमें gastric dyspepsia रहता है, poor gastric emptying होती है. You might get benefit of adding a prokinetic over PPIs. So that's a small catch, small niche where prokinetics can be added. I think it's not important. Treating the nerves, not just the acid. Again, GERD beyond acid control. The role of gut-brain axis. Stress amplifies symptom perception. Symptom perception gets amplified. Anxiety, hypervigilance, worsen symptoms. There is overlapping functional gastrointestinal disorder. So these are the patients who are not going to be benefited by just PPIs, or they are not benefited at all. So behavioral therapy will be important in these patients, and using neuromodulators will be very important. There is a role of gut-brain axis in GERD also. not our own ideas. This is what my first slide said. Our treatment plan should be phenotype based. So what is phenotype driven therapy? Persistent acid reflux. Switch PPIs, add H2RAs, check H2RAs, role of TH-TSA inhibitors, ultimately fundoplication. ये एक phenotype है GERD. एक दूसरा phenotype है non-acid reflux. या acid है LGNAs. LGNAs to prevent the biliary fluid which is coming in the esophagus. Alkaline acid reflux to prevent that. Baclofen, propanedics. I think baclofen को मैंने जानबूझ के हिकअप्स हाईलाइट किया because जितने भी हम लोग फिजिशियन हैं हिकअप्स देखते हैं सब लोग baclofen लिखते हैं. Everybody writes it. That's why you write it. Because baclofen decreases the transient lower esophageal sphincter relaxation की frequency. तो relax होता है ये sphincter, ऐसे ऊपर आएगा नहीं, हिकअप्स prevent होगा. There is a role of baclofen in non-acid reflux. Hypersensitive. जैसे मैंने एग्जाम्पल दिया, किसी को एक चम्मच में चीनी जरा सी पहुंच जाती है, बहुत सारा एसिडिटी होता है. These are hypersensitive. There is a role of PPI plus neuromodulator. Some role of hypnotherapy also. This is the third phenotype of GERD. The fourth one is functional. ऐसे में PPI बंद कर दीजिए, neuromodulator दीजिए, आपका पेशेंट अच्छा हो जाएगा. Believe me, you will get 10 more patients of similar symptoms if you treat this one. You won't miss it. So there are 4 phenotypes: persistent acid reflux, non-acid reflux, hypersensitivity, and functional. I am coming to the end of my talk. So advanced medical management includes long-term management, objective level GERD, severe reflux esophagitis, Barrett's esophagus, motility disorder, large hyperuricemia, troublesome extraesophageal symptoms, morbid obesity. Then these are the options: endoscopy versus surgery. I am not going to details on these therapeutic modalities. So what is refractory GERD? हमने बहुत सारा बात किया GERD beyond acid control. हम बात कर रहे हैं refractory GERD. How do you define that? No response after 8 weeks of therapy. Genuine compliant therapy. If it is not there, send this patient to a gastroenterologist to do an endoscopy and rule out eosinophilic esophagitis. Sir, हम आजकल ये भी देखने लगे डॉक्टर eosinophilic esophagitis, not many, but if you start looking for it, you might find a few of them. These patients predominantly present with chest pain and dysphagia. So if you have GERD with these symptoms, look for eosinophilic esophagitis. So what is personalized medicine in GERD? Again, GERD beyond acid control. Up to 50% patients do not achieve adequate relief and then PPI therapy alone. Personalized approaches reduce unnecessary long-term PPI usage. हम लोग किसी को इतना टाइम ही नहीं है कि पेशेंट इतना सारा टाइम देंगे. But personalized approach is important. Improve symptom control and minimize adverse effects. They also help distinguish GERD from mimics such as eosinophilic esophagitis and functional dyspepsia. It's about AGSA about it. So what are the future directions? हम कहाँ जा रहे हैं GERD? We need to get more of mucosal protective therapies. Precision phenotyping, that's what I told you just a few times back. AI सब जगह जा रहा है तो यहाँ भी उसको आना ही है. AI assisted reflex analysis. Again I said personalized care, personalized GERD management pathways, and obviously it goes without saying integrated GI and behavioral care. So what are the important take-home messages? GERD requires individualized therapeutic approach. PPIs continue to be the mainstay of treatment in GERD patients. PCAPs are a promising class of drugs that provide benefits over the current standard of care of PPIs. Endoscopy of this surgical procedure is less desirable and should be restricted to refractory cases. Patient selection is very important. Thank you so much. My final slide is managing GERD, think beyond acid control. Thank you so much.
Thank you, sir. Because of the dietary pattern or genetic predisposition of people in some quantity.
Which causes all these symptoms? Because lifestyle is a very important area in this. I have not touched in that, that's something we all know about. But it's more of lifestyle pattern which causes all these symptoms more in our population. फिर हम आजकल abdominal birth की बात करें, Indian is in obese capital, more predominant abdominal obesity. It is not increase more.
So one common
problem we face. You said PPIs for 8 weeks. As soon as you withdraw, that same symptoms of burning sensation throat reappears. How long?
Dinesh, it's a very important. I thought I would touch on that, but the time was short. There is a debate whether PPI and opium, new opium for gastroenterologists. This is a meme which keeps on running us. PPI is a new opium for gastroenterologists. एक बार PPI किसी को शुरू कर दो, छोड़ नहीं पाता. Actually, the problem is if you go deep into it, what happens is if you take PPI for 8 weeks and you stop it, symptoms are bound to come back. But then if you patient is able to sustain that for another 10 days, symptoms disappear. That never happens because the moment symptoms come back, आप नहीं भी लिखोगे तो कहीं और तो लेके खा लेता है. So there is a amount of symptoms for next 2 weeks and then it disappears. वो time frame नहीं मिलता.
And you said no major role of prokaryotics, but you must have also experienced, we have experienced that once you give PPIs, only PPIs, even in GERD, patients are not satisfied as soon as you add the prokaryotic. That's the response comes.
I would agree with you. This is something which I have said in a lot of meetings also, that my patients are happy having a combination instead of drug alone. I don't know the reason behind it. But I was always told, there is no scientific evidence to say that. Once I went through this literature, I would find that I believe these are those subset of population which have probably esophageal dysmotility or to some extent, some poor gastric emptying which is there. So this prokaryotic helps in that area. So Domestal is known to cause some NES tightening also. That's how it might be helping us. But again, scientifically, yes, we should use PPI.
Any questions from the audience before you wind up?
Most of the people know. The second point is that there are toxic effects. There is magnesium deficiency, B12 deficiency. There is gut biopsies and all those symptoms. Do we get that with PCA too?
The data is still limited, but I believe it should be there also. Because why it should not be there? Because PPI causing these malnutrition or vitamin deficiencies, calcium, osteoporosis is because of severe acid suppression. So PK will also doing the same thing. It will give a prolonged acid suppression. We don't have data till then, but I think data will be similar as PPI is concerned. But the reason behind it is acid suppression.
I think your presentation was excellent.
Thank you, sir.
And very eye-opening. Very good.
Thank you, sir. Rakesh, you had a question?
chair the session and introduce the speaker. Over to you.
And he is specialized in kidney transplantation, CKD. dialysis and critical care we have all done. Dr. Kumar Pandey, please.
Per 1.73 meters square with medical history of hypertension and gout with recurrent self-limiting episode of podagra. There is a recent UTI infection in past, recent, and there is also past history of UTI infection. In family history, father with end-stage renal disease, presumed secondary to with diabetes mellitus. Patient is on current therapy with amlodipine and telmisartan for past 4 years with past history of taking hydrochlorothiazide but discontinued. Before referred to gout management, history is taking allopurinol due to generalized maculopapular rashes, but patient withdraw the allopurinol and come to our OPD. Vitals is same. The serum uric acid was 12.2 mg per dl, creatinine 1.9. We do the biopsy in this patient. Biopsy shows the chronic interstitial nephritis with moderate interstitial fibrosis, tubular atrophy, focal lymphocytic infiltration, and minimal glomerular involvement. Now the treatment consideration, SGLT2 inhibitors we have considered but differ due to recurrent UTI. Urate lowering therapy, Febuxostat initiated at the 40 mg per day and up titrated to 80 mg per day after 4 weeks, targeting serum uric acid level less than 6, and lifestyle is also taken. In follow-up patients, uric acid reduced to 6.1 at 1 month, maintained less than 6 mg per dl from month 3 onwards, and renal outcome at 6 months serum creatinine improved to 1.5 mg per dl with eGFR increasing to 48 ml per minute per meter square, and proteinuria also decreased to 0.28 gram per gram. So the conclusion of this case is Febuxostat therapy resulted in stabilization of renal function despite the absence of SGLT inhibitor therapy or recent ARB initiation. This case support considering Febuxostat as important adjunctive option in selected patients with CKD and hyperuricemia, particularly when alternative therapies are contraindicated. Thank you.
So what is the value of serum acid as you told depend on symptomatic or asymptomatic? So is the value different in these two groups?
I already mentioned that in case of asymptomatic hyperuricemia, in CKD patient, category is not recommended to treat any patient. If patient is symptomatic, for any serum uric acid level is more than 7. For male, more than 6. If patient is symptomatic, we go for the treatment for urate lowering drug. But if asymptomatic, even in CKD patient, category denied for any treatment.
But there are trials also with benefits. And we show the benefits that he has beyond that can give.
So there is a lot of studies. There is a controversial is there, like CKD fixed trial, in which allopurinol is used for in case of CKD, and this shows allopurinol have no effect in CKD, reducing CKD progression, even lowering the uric acid level. Similarly, there is a feather trial in which Febuxostat used in CKD patient, hyperuricemic CKD patient, and this also doesn't show any benefit. That is, lowering uric acid level have some beneficial effect on CKD progression. So this is very much controversial topic. But in free trial, it shows that if serum uric acid is high, beyond 8 or 9, and we keep the target of 5 to 6, there is some benefit that is reduce the CKD progression or overall cardiovascular mortality. So, but in various, there is a conflicting data is there. But at present, CADICO doesn't recommend to use treat asymptomatic hyperuricemia in CKD. Whatever is mentioned is if it is a more than 9, we go for the treatment.
Your presentation was excellent of a hyperglycemic patient. You have hyperglycemia, you have uricemia. Both are causing increased stroke, eye problems,
Yes.
cardiovascular problems and increasing mortality, increased atrial fibrillation, more CHF, progressive loss of kidney function. Same thing is being produced by uric acid, although it is not that strong as hyperglycemia. Now the treatment. You have very rightly pointed out that you go for oxidase inhibitors, But why not uricosuric agents? Diabetic drugs like SGLT2 will do the function of uric acid excretion also. And they would help uric patients also, uric acid patients also. So shall we recommend more of the uricosuric agents, or let us say shorter? It is uricosuric and hypertensive agents should be given. What is your opinion about that?
Sir, I already mentioned, sir. Yes, sir. Because most of the data at present till date is available for xanthine oxidase inhibitors. Urate lowering drug, xanthine oxidase inhibitor is commonly used for treatment of hyperuricemia. Uricosuric drug, the data is very limited at present date. But in future, this type of drug is more beneficial for a slowing the CKD progression or reducing the cardiovascular mortality as compared to xanthine oxidase inhibitor drug. But at present data is lacking.
As sir has told, it is a patient of metabolic syndrome with all these complications with hyperuricemia. Which one is the preferred? SGLT2 inhibitor or febuxostat? Or you have to give both?
No, sir. In metabolic syndrome, if patient is asymptomatic hyperuricemia, we generally go for the SGLT inhibitor and febuxostat. Uricosuric drugs, febuxostat is a xanthine oxidase inhibitor. They reduce the production of uric acid. This doesn't work on the, not increase the excretion of uric acid. SGLT inhibitor is recommended.
Nowadays, what is the use of allopurinol?
Sir, today date is also drug of choice for hyperuricemia is allopurinol. Most of the physicians or most of the doctors commonly use the allopurinol as the first drug. But nowadays the role is shifting to the febuxostat because it is little bit less side effect, less chance of hypersensitivity reactions. But most of the physicians and use allopurinol as the first drug. Both efficacy is same. There is no difference between the efficacy. Most of the trials show that febuxostat is not inferior to the allopurinol for reducing the CKD progression or cardiovascular mortality or reducing. So the efficacy wise both are the same, but side effect is little bit more in allopurinol group. That is why we are shifting toward the febuxostat nowadays.
The combination of fluorescent with allopurinol was very commonly given by our teachers. So that can be done. No problems about that.
Yeah, but in acute.
Sir, we share few patients with you. I have patients of chronic liver disease with renal failure. You get a uric acid done. What level should I treat it? That is one. Two, I have patients of acute liver disease with renal failure. Get a uric acid done. What level should I treat? And third part is, you mentioned alcohol. Do all types of alcohol need to increase uric acid, or certain type of alcohol is more important?
Sir, like yes, sir. I start with the alcohol first, sir. Beer, in a beer, this is the purine content is very much high. Or that alcohol which have a more purine content have a more chance of developing the hyperuricemia. Second, in CKD patient with hyperuricemia, first my clinical scenario is that if serum uric acid level is more than 8, first CKD then serum, sir. Any patient, I already mentioned this is the Indian Forum guideline. This is the already mentioned that if serum, even in asymptomatic hyperuricemia, always to treat in any group of the patient, either CKD, CLD, any patient with symptomatic hyperuricemia should be treated. Second is the asymptomatic hyperuricemia. The studies like category recommended not to treat in CKD patient if it is asymptomatic. But this is the Indian Forum of Hyperuricemia recommend that it should be if patient with asymptomatic hyperuricemia with comorbidities like diabetes is there, which is not good control. Cardiovascular, if there is a high risk factor of cardiovascular disease or CKD patient, it should be treated if more than 8. For all patients, if more than 9 should be treated. 8 to 9 is the conflict area. Below 8, it should not be treated. In CRD patient, if more than 8, I think it is a good to start the treatment.
Since we are running short of time,
Now conclude the session for the next session.
and the chairpersons will delegate the speaker. Chairpersons to felicitate the speaker. is neuropathic.
Those patients who have got subjective symptoms, they usually do not disappear. Despite all the treatment, psychological as well as medical by new people, we usually fail in those patients.
I guess there's a like 100% recovery cannot be expected. That 100% recovery you mean to reverse diabetes, it's a very difficult thing to do. But definitely these drugs are very much effective. A combination is needed in many patients. The only thing which comes to my mind is there are not many topical applications of gabapentinoids which are used. So what does the literature say about use of topical gabapentinoids in the treatment of diabetes?
So the guidelines do not recommend the topical application of these drugs. Only topical application, and that too approved by FDA is
that the audience must know that these are not a proven mode of treatment of painful diabetic neuropathy. And
very nice presentation. For the sake of juniors or students who are sitting here, that before we label the patient to be having diabetic neuropathy, we'll have to exclude other causes like B12 deficiency also, because patients might be on metformin and that gain predisposes.
Sir, your comments.
My comment? तुम लोगों ने बहुत बढ़िया किया. मेरा एक ही comment है. In my 50 years of going through medical conferences all over the world, I have not seen a father and son duo chairing a session. So there is very
They often have these neuropathic pain and symptoms. How do I treat them? Because sedation is a major concern for me as a gastroenterologist. We have ruled out B12 deficiency, folic acid deficiency. What do you do next?
So among these three classes of drugs, sir, this gabapentinoids are excreted by the kidney. So they would be relatively safe in patients having liver disease, and they can be considered. The other two classes of drugs, tricyclics and SNRIs, they do have liver metabolism and cytochrome P50, so they may have problems. So, I mean, if there is a patient with liver disease and you have to treat, maybe going in with the gabapentinoids can be a safer option.
What about sedation? Like they often call them.
Yeah, that is a problem. So,
for me, as a sedated CLD would be more of a medical encephalopathy than anything else.
yes. So, we can start with a low dose, but that side effect definitely will be there. So, one has to be cautious in using them in patients with liver disease.
Role of carbon
That is 25 mg. Is there any dose dependent therapeutic is here in the study?
The effective dose, you will have to go for a higher dose. Like for pregabalin, sorry, it's not being. So they say start with 25 to 75, that is your starting dose. And then you have to, you can go up to 300 to 600, but practically all of us know that going up to 600 or for gabapentin 3600, I don't think it's possible. So maybe start with a low dose, and as sir was saying that problems may be there with relation to somnolence, dizziness and other things, so that needs to be monitored.
We can go in for the local applications, capsaicin can be used, but
Topical applications can also be used.
So what is the role of palmitol?
It's not there in the
guideline. That will come to the close of the academic session. So it was an excellent talk by Dr. Vaman, and he deserves a big
We should thank Satish also for a good moderation of the session.
Just go away. There's a simple and most important thing. I would like to extend a special thank note to our moderator, Dr. S.C. Joshi sir, and to facilitate the same, I request Upinder sir and myself, please come and do the honors. Come on guys, a big round of applause for Dr. Joshi for making this event a memorable one, and he is the one who has contributed and done the steering of today's scientific session. His efforts and support played a vital role in making this program engaging and more successful. Thank you so once again. So now to give away the vote of thanks, I request Mr. and also Mr. Mahesh Pigle, the NSM for Team Excella.
Special thanks to our moderator sir, S.C. Joshi sir, our program director Dr. C.G. Agrawal sir, along with our panelists Dr. Puneet Mehrotra sir, Dr. Sant Kumar Pandey sir and Dr. Vaibhav Shukla sir for their valuable insights. I would also like to extend my gratitude to the API chapter, Lucknow chapter. I would like to thank my entire MAX team for putting up efforts and making this MedHance a grand success. With this, I would like to call that today's MedHance event, closure of today's MedHance event, bridging the expertise and enhancing the care. Thank you very much all. Thank you.